Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Dr. Joseph Maccio, and he will talk about his study, the application of mechanical diagnosis and therapy in lateral epicondylalgia. Dr. Maccio is a physical therapist, holds a diploma in MDT, and has several MDT-related publications. I hope you enjoy the show.
PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi, Dr. Maccio. Welcome to PT Pro Talk. How are you today?
I'm doing great. Thanks for having me.
Awesome. So let's go to our last one of our series about your papers. So just a brief introduction for the ones that haven't listened to our previous episodes. They definitely should go back and listen to those. But for the ones that don't know, you just briefly talk a little bit about yourself.
Sure. Yeah. Well, I would definitely recommend going back and listening to the first two podcasts because, in my opinion, and I think yours as well, they were just a game changer and excellently.
Absolutely.
Done, so I'm excited for them to come out. But yeah, I am a doctor of physical therapy, a diplomat of McKenzie method. I graduated from school in 2008, Downstate Medical Center, and continued on to become a diplomat in 2013. I previously worked with my father at a certified McKenzie clinic. We're the only father and son diplomats in the world that I know of, something that we're both pretty proud of. And and since that time, I have published a number of studies involving the application of MDT to the peripheral joints.
And today, we're going to talk about your study about the lateral epicondylalgia, right? So let's just start talking a little bit about it. Just give us like an overview about this study.
Sure, yeah. So this was actually my first study to ever be published. And it was shortly after I finished my diploma program. And it was interesting because the clinical component of the diploma program in Austin, Texas, you live with someone else for just over a couple months, I believe it was. It felt like a lot longer than that for some reason. But and the gentleman, Richard Yarzembowicz, was very much into research, and I was very much a clinical person and didn't necessarily care that much about research. So we kind of meshed well and rubbed off on each other well in that sense. So the pairing of that, I don't think was intentionally done for that reason. But we were just two young guys at the time. I guess I was still in my 20s. And we were just interested in pursuing some new things and pushing the boundaries a little bit within MDT. And, it was kind of like after I finished the diploma program, I'm like, well, what do I do now? I've been pursuing continuing education and just progression in my profession for so long, and what's next? So I was kind of just looking for something to stimulate me and take on. And there's something about there was a randomized control trial done by Combs et al., which was Vincenzino and Bissett, and they published a lot of things on lateral epicondylalgia and the application of the Mulligan technique to that using, I think, mostly the lateral glide technique that is very popular within that treatment method. And basically, the randomized control trial showed in the long term, this form of multi-module treatment with the mobilization wasn't any better than doing nothing. And the medical intervention of cortisone injection had a 70% higher recurrence rate of symptoms in people. And I was like, I don't see a lot of elbows, but I was like, that's horrible. That's not at all what I see. And I think someone should publish something about the efficacy of MDT in elbow problems since it hadn't been done. And I also thought it was kind of crazy that there was a lot of extremity joints that weren't published at the time. Thousands of articles regarding spine, but the periphery was kind of the new frontier, and it excited me. It felt a little more confusing, and it was just an opportunity and just an idea to. I was kind of like, I'm going to try to validate and publish every extremity joint out there that can be done. So we did the elbow, the wrist, the ankle, the hip.
I love it. That's a good goal.
Yeah, and so it was really cool. And initially, I set it as a larger case series. It was done as 7 patients, just general elbow pain, not specific to lateral epicondylalgia. Same thing, just consistent people that came through the door. And it was a really cool study. A lot of interesting reductive movements and patients, and advocacy was great. It averaged like 90% improvement within I think an average of 13 days, averaging like 3 visits, which was and that at the time that was at discharge, and then most maintained, I believe, at 3 months for that patient set. So excellent short-term outcomes. And we got Stephen May, who was published, he helped co-write the new McKenzie books, interested and and on the paper, and helped edit and stuff. So it was, as a first paper, I was like, oh my God, we're in a whole new level here. This is crazy. And people loved it. I shopped it around to everyone, and everyone was so excited about it. Pushed it through JMMT, and it got just completely ripped to shreds and denied. And I was like, oh my God, what? Oh. I'm so passionate about this. It looks so interesting. Like, how could you do this to me? And it was devastating. And I mean, on a personal note, I'm recently separated from a marriage. I think the loss of this publication was even harder than losing a marriage, to be honest with you, to put that in perspective for
that's funny.
So, but in talking to some people, I realized that's something that happens, especially your first time around. You kind of vet it. And the gist of it was that they wanted a case report since it was never done. And I was stubborn and said, that's ridiculous. I don't know why I didn't, because it would have been easier. But in really taking a step back and looking at the paper, what we were really trying to do was prove the efficacy of MDT on lateral epicondylalgia, not just general elbow pain. So we just walked 3 of those patients out that had either fit the diagnostic criteria that randomized control trial used, or had a medical diagnosis and also fit the diagnostic criteria of LE, or lateral epicondylalgia. In the paper, this is acronymed as LE, which is a little easier to say, so maybe we'll refer to it that way.
I like that.
Have an easier Thursday night here. Yeah, so that was kind of the premise of it. I've always been a little interested in the elbow. I don't see it a lot. It's like one of those just weird joints like TMJ that you get, or I get at least here and there, that I was interested in pursuing. And and just there's something about that randomized control trial that just really stuck with me. I was like, how can that be that it's a form of treatment that I think is pretty good and it makes sense, and they're doing a little bit more than the average person, isn't yielding effective outcomes. It was just embarrassing almost. And I said, we need to show something better. Yeah. So that was the premise of why it started. And then, I guess if we just kind of get into the paper, I'll just walk through the different sections of it. So in the background of it, looking into lateral epicondylalgia, I forget the timing of when this happened, but it used to be called lateral epicondylitis, implying that it's an inflammatory state of the tendon. There's been a lot of research out there that has negated that. Histological dissection that looks at people with symptomatic LE, and there's no inflammatory cells. So the use of inflammatory treatment doesn't make any sense because it's not an inflammatory state. So, and why you see this high, I think at least, this higher recurrence rate in people that have cortisone injection. Because cortisone is good at killing inflammatory cells, but it eats away at other tissues. So if you weaken the tissue, of course it's going to fail. So if you're really looking at that research, I think it's really interesting, that whole histological dissection and not finding inflammatory cells. And because of that, the name was changed to lateral epicondylalgia as just a generalized term, and it's mostly implied that that is a degenerative tendon. So it's a tendon issue that was injured, that has since healed improperly, or over time has just become weakened and then causes dysfunction and pain with different functional movements. And there's a lot of research on that. There's kind of an interesting anecdotal story of a European, you probably know this story, a European guy that he had Achilles tendonitis. He was a surgeon. I'm forgetting his name, which is not like me. It's probably because I've been lacking sleep the last couple of nights with my daughter. I'll blame her for this. But basically, he was like, I want this surgically repaired. His partner wouldn't do it. And he was like, well, I'm just gonna rupture it.
Oh,
so
yeah.
do it.
Oh,
And
yeah, I
he
heard
started
that
doing
story.
this ballistic eccentric loading, rupture his tendon, and then over the course of a few weeks, it got better. And he was like, this is crazy. And so all this eccentric loading came about because of it. Now, on my end, that doesn't completely make sense, because a tendon shouldn't remodel in 3 weeks or whatever the anecdotal time frame was. It was likely this guy had an ankle derangement that cleared from ballistic high velocity dorsiflexion rather than the eccentric loading of the tendon. And I think that skewed the research a little bit, because I don't think eccentric is necessary to remodel. But anyway, there's a whole history in that that's kind of interesting. So in further looking, what we know about derangement and derangement mimicking these pathoanatomical syndromes, which in our first podcast together, when we look at directional preference of the extremity, there's a list of tons of medical diagnoses that actually are derangements that exactly mimic the presentation of this pathoanatomical problem, which is either an inflammatory state or a tendon issue or something completely different, or it might even be spine referral. And I was really interested in, like, how does that work, and who are the people that can kind of that support that for research. And probably the most relevant article that I found was the Mercer-Bogdanoff article, where they dissected cadavers of elbows to determine, is there this kind of loose articular tissue that's innervated that can cause nociception, that can cause obstruction of movement, that can potentially become mobile and entrapped in the joint space or outside the joint space. And they found 3 different structures that can do so. And it made sense in my mind, like, oh, well, this is what a derangement is. There's these things that just get malaligned in there. You move them the right way. It either puts it back where it came from and gets it to heal that way, or potentially completely remodels the tissue and absorbs back into the system. Or that level of thinking is kind of above my thought process, because I'm just a clinician that dabbles in research, I suppose, on podcasts now. But regardless, most research, there was a quote in the study that says, despite continued research, the true origin of pain for LE remains an enigma. So people don't completely understand what's happening. So I thought this article was nice.
That's crazy how it's so many misconceptions about that still today, and how ineffective the treatment can be. It's just crazy.
What's interesting, when we get into the discussion part, there's a paragraph that talks a little bit about the history of it and what other people have done, which was more indicative years ago, even dating back to the 1930s, that it was a joint problem. So the answer was right a long time ago. And for some reason, it's probably the over-medicalization of American medicine, at least. Give it an anti-inflammatory, give it a cortisone injection, give it a bunch of silly strengthening exercises that we learned in PT school, or brace, or whatever, or ultrasound, or so anyway. So we get into the methods of this. There's 3 examiners that were used. I was the main clinician. And in the risk study that we talked about last week, I gave students a lot of freedom to assess patients, treat patients, and I kind of oversaw it. In this study, it was my first study. I really wanted it to go well. I really wanted good outcomes. So I didn't let them do nearly as much. They were involved in the creation of the study and stuff, but they didn't see patients independently. It was more me seeing them. They would be kind of participating and stuff. But yeah, so we used the same diagnostic criteria as that study that I referred to that was in JAMA. Same special tests to rule in and or if someone had medical diagnosis, which 2 of the patients did. And then screen the spine, and that's in the method section. And then yeah, I guess we're kind of ready to get right into the patients, the 3 patients, unless you have anything more you want to know about methodology or background.
No, I think it's very clear, everything, all the steps, all the tests you done, the inclusion criteria and all of that.
Yeah, so it might be good just to go. So yeah, the special test, because this is another point in the discussion that we talk about, were let's see, you had to have at least 3 out of 10 pain, and you had to have pain provoked by at least 2 of the following orthopedic tests. So it was gripping, palpation of proximal wrist extensor tendon, resisted wrist middle finger extension, or stretching the forearm extensor muscles. So those are also the Cosins, the Mills, and there's one other orthopedic name that I'm forgetting which one it was, but that was how it was reported in JAMA. So we just used that instead of the names that are associated with them. And then all of the movements that we use, I think this might be kind of relevant too. We wanted to just in some regards, I feel it's not fair to call what we do exercise. I exercise to stay healthy, and that's completely different than what I prescribe to a patient and the intent of it. So I've always felt like saying that to someone is confusing. And if you think about it, I would never, do bicep curls 10 times every hour. It's ridiculous, but the purpose of this is different than what you think of in traditional exercise. And I think just talking about it that way makes the patient think about it a little differently, and describing it as a corrective movement. In this, we call it loading strategies, and then said that it was intended to be end range self-joint mobilization, not an exercise. And then went on to describe it as either loaded, partially loaded, or unloaded in regards to weight bearing. So hear that through the course of the patients. Okay, yeah, so for the first patient, 57-year-old female registered nurse. I don't know about your experience. Nurses have been one of my hardest patients. They think differently. They don't like what I have to say often. Initially in my career, connecting with them and getting them on board with MDT was very difficult. I've figured out how to get that done as I've gotten older and more skilled at communicating with people. But anyway, I was like, oh, great. This person's going to be, just this angry nurse that doesn't want to do anything I'm saying, and kind of was giving me that vibe. And she's going to completely mess up my study, and it's going to look horrible. We're going to have the same horrible results as this other randomized control trial. Oh, it just seemed like a horrible start. So anyway, she had intermittent left elbow pain that commenced for no apparent reason, and had pain with mid-range pronation and supination, which was part of an exercise routine she had. Her upper extremity functional scale was 68 out of 80, and her average NPRS was 6 out of 10. No other treatment, no medical diagnosis. So just from that history, there's a lot you can pull from that. which I think is really helpful and interesting to think about. So the time frame, the 6-month time frame, and predominantly intermittent symptoms really should rule out that it's an inflammatory state. It should be constant. Unless this person just has no regard for themselves and just continues to kick himself back into an inflammatory cascade, why would it go on for 6 months? It doesn't make sense to me. So those two factors made me think this isn't an inflammatory state, and likely that can be maybe not completely ruled out, but much less likely. And then, so if we rule that out, we're kind of looking at, there's no trauma, so you wouldn't think that there's structurally compromised tissue or fracture, or rupture, or anything like that without a trauma. And then we would be left with either that time frame dysfunction, articular or contractile, could be present. And if you look at what worsens her, it's mid-range movement. So the definition of an articular dysfunction should be pain only at end range. So if we're dealing with a dysfunction, it would be more likely that it was contractile than articular. So we're kind of down to that and a derangement. And the spine had already been excluded, which was reported in the methodology just to make the case report a little cleaner for people. And then postural syndrome is something I basically never see in the periphery, and just again the nature of mid-range movement causing it also rule that out.
I love the rationale that you put in the order that you put on the way you describe it, that walks us through like thinking about, okay, you have the subjective, what can you exclude, what could be, and then you start thinking about it and already putting like, okay, that may be a derangement and a contractile dysfunction. So I really like that helps the clinical reasoning. So I noticed that you do that in all of them, and I think that's really helpful.
I agree, yeah, and especially when potentially dealing with this cantankerous nurse that's going to give you a hard time, getting there efficiently is very important. So I think that being able to pull that out in real time and start to navigate that diagnostic process, that flow makes sense. And I hope that the reader of these articles gets that from that, and I hope that more people, I've heard that from a lot of people, that they really like that flow and that part of it, which thank you for saying that. Yeah, so on physical examination, she had lateral elbow pain that was produced by gripping palpation of proximal wrist extensor and stretching the forearm muscles. And so she ruled in for the diagnostic criteria of LE, pain was enough. And then range of motion assessment showed a minimal loss of elbow flexion, and it was minimal loss of elbow flexion, end range pain, and minimal loss of elbow extension without pain. So by the definition of a contractile dysfunction, there shouldn't be movement loss. So that starts to build the case that that's less likely. And maybe she just has always had a discrepancy in elbow range of motion. We won't know that if we're moving, but just it makes that likelihood more so that it's a derangement, and that which needs to be excluded regardless if you're going to call something contractile dysfunction, because the treatment of that is a much different, longer path than how a derangement would be managed. Yeah, so this is based on at the time, this was before we did the risk study, before we did this extremity study where we tried to find directional associated variables with directional preference, mechanical stress, and directional vulnerability, and structural movement. At this time, this was published in 2016, but it was probably 2013 that I was assessing this patient, so quite a while ago. And for me at the time, elbow extension was just one of the most productive movements, so we just jumped to that and to see what would happen. So we went right to loaded elbow extension, just put a lot of force through it, and that and had patient overpressure applied. And at the time, she did have resting pain, which repeated loaded elbow extension abolished resting pain and abolished pain with elbow flexion. So 2 big changes right off the bat. Especially once that happens with someone that may not be involved, they don't care necessarily anymore because they see it feels better. Okay, I'll do that. So you get that day one. It's really helpful for compliance. And then motion was better. Pain with gripping decreased, but it didn't abolish. But multiple things like that happen positively. In my experience, it increases the likelihood. That's directional preference, and you're going to get positive result. It's just about getting compliance. And yeah, so when that happens, right, that is the characteristic of a derangement. A degenerated tendon or contractile dysfunction shouldn't see rapid change like that. So, that really, in my opinion, confirms that we're dealing with a joint derangement and not a pathological tendon or degenerative tendon. So we sent her home doing that, high frequency, end range. Didn't tell her to not do anything, told her to keep exercising and working, doing whatever else she wanted to do. Reps were prescribed at 10 reps every 1 or 2 hours. We resaw her in 3 days. Usually I'll see someone 1 to 3 days, I guess, for follow-up, depending if it's confusing or scheduling or whatever. And she came back reporting 65% better. So pretty good for a few days, I think. She was happy. She was able to fully participate in her exercise class, which was her most important, what she cared about the most, I suppose. She was very happy with that. And then all sympathetic baselines were improved, and testing loaded extension also continued to have a positive effect on any of the baselines that were there. So it reconfirmed directional preference. And I think this is an interesting juncture because this woman that originally just seemed like she might be a difficult patient, comes back day 2, she's a lot better, and I don't do anything. Just go do the same thing. It's working. We'd be crazy, and I'll often say that it would be crazy to change anything. This is working. We're that much better that fast. That's wild. Most of the other research shows in a year you're not going to be any better. So let's run with this. And most people will understand that, but I think that especially as I was a newer MDT clinician, there was it felt odd to not do something different. Where it's kind of like, what is my value? This patient wants more. Doing that likely would have made it worse. Or made her compliance less.
But I guess you just feel you have to do something different, provide something else.
Right. And yeah, that's against us human nature. But I like to stress that because a lot of people are that way. And I think there's a lot of failure within younger clinicians that feel that same thing and haven't had the experience to know, I just stick with this, it's going to work. So yeah, I think this is a really nice patient to exemplify that, because in a week we saw her for the 3rd time and she's 100% better, completely better, no pain, no motion loss, no baselines positive, no functional limitations. We saw her for 3 visits in 11 days, completely better, same move for the whole time. So we got it right the first time and it works. And that's interesting because it was the first movement we picked just because it was like, that's what I do a lot. Let's see if it works. So I guess we were lucky in a way.
Right on. Yeah.
And then we followed up with her at 3 months. She had no recurrence of symptoms. We followed up with her in a year, and she had said it came back a couple times. And I just did the move a few times, just did loaded extension a few times. It went away. I'm happy with that. I don't really care. I know how to manage it if it comes back. And I'm here trying to get my numbers to look good for this study. And I'm like, what the heck? Do it a little more prophylactically, like I told you to. She's like, nah, I don't need to. It came back, it wasn't a big deal, and I fixed it. So I'm happy enough with that. But I think that's kind of cool also because she's independent now. She's not seeking other healthcare. She is seeking me, and she knows what to do. And that's her comfort level. Some people don't necessarily need to hear a year I'm 100% better. They just want to be a lot better and be able to live. So
yeah, and do what they like to do. So I guess that was a good first patient.
I wouldn't have guessed it. I was like, this is going to be a disaster, but you never know. And,
Yeah.
and if you get it right, it all makes sense. That difficult patient, when they find something of value that works, they became a very not difficult
They
patient.
comply.
Very compliant and happy. That's always interesting and good to see, because the beginning part of it can be almost confrontational or uncomfortable or whatever, and that deter you from doing the right thing. At least for me, it used to make me feel like I need to make this person happy, not do the right thing. But with more experience and seeing where that leads, it's become easier. So yeah, so that was patient 1, straightforward, loaded elbow extension, cleared the whole thing out very quickly. Patient 2 was a 75-year-old retired male. He had intermittent right lateral elbow pain. He was given the medical diagnosis of lateral epicondylalgia, implying that it was an inflammatory state from his primary doctor. And it began suddenly 4 months when he was cutting wood, and his symptoms worsened when lifting heavy objects, shoveling, using exercise equipment that involved elbow flexion and extension. He had no comorbidities or previous treatment. The upper extremity functional scale was 73 out of 80, average pain score 5 out of 10. So in the differential of this person, 4-month onset and intermittent symptoms, just like with the last patient, really ruled out that there's an inflammatory state, in my opinion. There might be someone that disagrees with that, I suppose, but from the operational definition of the inflammatory state, it should be a constant thing. So the diagnosis from the medical doctor was completely wrong, and just probably his just verbiage. He didn't even think that, just to get elbow pain, epicondylalgia. But the implication of that is treated with anti-inflammatory, which wouldn't have done, as we see how this walks through, or so the 8 weeks did allow for articular and contractile dysfunction to be present. Pain during functional activities that were in the mid-range, just like the last patient, should kind of rule out that there's an articular dysfunction. Now, I've seen people that have an articular dysfunction, that have pain during mid-range, and I think of it almost like, if you think about your shoulder, if you contract the joint space and there's abnormal tissue in there, you might cause some compression that tautens that tissue or compresses that tissue, and you get this false, I guess it's not a false report, but it doesn't fit the operational definition of articular dysfunction being at end range, and you'll get some pain with mid-range movement, just because I think the joint space tautens and you feel that. But that's my own just thing that I've experienced. I don't think that would be said on an MDT course or even for anything. But I've had a lot of weird things that don't completely fit, but they should. And I think that's important too, because there obviously is discrepancy in how people report, and every problem is different. So that is probably helpful for a lot of people.
Yeah, I think that's how things start. You just start observing, paying attention, and seeing the pattern repeating itself. And
so from this, we are in the same diagnostic differential as the last patient between contractile dysfunction and derangement. So in physical exam, same thing. This person has a minimal loss of elbow extension with pain both with flexion and extension. Lateral elbow pain was provoked by gripping, palpation, resisted wrist and middle finger extension, and that ruled in the diagnostic criteria of LE. And then same thing, we went right to, I guess, my old standby, just loaded elbow extension, just pushed right into it as hard as we could right off the bat, which probably now I would start in an unloaded position, see what happens. If it goes well, then start to load it up. In this, I think I was being a little more cavalier because I just wanted fast, good change. I was all excited. I was a new diplomat. I wanted Stephen May to be happy with my and yeah, I was just trying to elicit bigger changes faster. And just let's see. So loaded wrist extension right off the bat. This resulted in less pain with gripping, abolished pain with palpation, and wrist and finger resist extension. And then that was enough at that point for me to go, yeah, we've abolished two things. One thing's better. This is going to be it for you. Saw him again, same thing, prescribed 10 reps every 1 or 2 hours. Saw him again in 3 days, and he came back reporting 50% better. So another pretty big change within a 3-day window. And he said that he no longer had pain with shoveling, but continued to have pain while lifting a coffee mug and heavy bags. So he still had a couple functional baselines. At this point, he no longer had movement loss at the joint, which is interesting because the derangement should initially have movement loss. And he, no movement loss and some baselines that are still present. So at this point, we just exhausted all forms of elbow extension. I had him push it a ton, maybe 50 reps, didn't do anything. I overpressed him, didn't do anything. I mobilized him into extension, didn't do anything. And so at that point, we felt that we had exhausted extension. I can't remember if we flexed him, but in this, we kind of compared the exhausting of the sagittal plane and spine to the peripheral and said, we've done everything that we applied as much force, as much time as we want to sagittal plane. Let's get into lateral or rotational movements. And I had said one of our, probably on the wrist podcast, that one of my first courses was a Mulligan course. In the Mulligan course, they have that lateral glide during grip. And I see that reduce pain a lot with people, and I'll use that as a quick differential, thinking if I alter the joint space and it changes grip, it's quick and easy to do. It's a derangement. And that might not be directional preference, but it makes me pursue derangement harder. So we did that with him, and that was positive. It reduced pain. So we started applying lateral force to the joint space during grip makes it better. Let's combine that with extension. So we had him laterally compress the distal end, or I forget if it was the distal or proximal end.
Proximal medial ulna.
Yeah. Okay. So he was on the ulna, so distal end of the joint, lateral glide, maintaining that during extension repetitiously, and no effect after. So we did a bunch of reps, didn't change anything. And so this was, I think, a really interesting patient for me because we're using this MDT assessment. There's positive Mulligan test, which I was interested in. Still am interested in the Mulligan technique and think there's value to it. And when I first started assessing patients, for some reason I was always just weirdly interested in the Mills manipulation. Have you seen the Mills manipulation performed ever?
I don't think so.
Yeah, if you YouTube it, there's a bunch of videos, and it's just this violent manipulation of the elbow of a practitioner.
Oh yeah. I saw that.
I used to do that occasionally just to see what it would do, which just when I was younger, it was just way too cavalier to try, but it was like, it's a thing, people do it, let's see what happens. And so I've always been interested in that technique. And in thinking about that, we were like, okay, we applied lateral pressure. I can't remember if we also applied medial pressure. I was like, let's try to mimic the Mills manipulation through repeated movement. So we flexed his wrists into full flexion, stabilized it on a table, had him go into full pronation, and then extend into end range extension while it's fixated. And that's demonstrated, or there's a picture of that in the paper. And It's also demonstrated on our YouTube channel for Maccio Physical Therapy if people want to see that in live technique. But it was basically the same pre-manipulative position of Mills manipulation, just with patient-generated pressure. So it was safer than just going after a manipulation, hoping it yields a positive outcome. And
yeah. And I'm going to put the video on the show notes so people can check that out. So you take a look at the notes. Yeah.
Cool. Perfect. So I kind of have like the McKenzie worlds colliding with the Mulligan world and the Mills world. And then this Mercer-Bogduk article I start thinking about, like, why is there no longer movement loss? And there's one sentence in this long, just, wordy research paper about pathoanatomy, where they talk about this displaced tissue, these meniscoids, capsular rims, and fat pads that can get displaced, have nociception, cause movement loss. And they talk about it getting displaced outside of the joint space. So in my head, I'm kind of like, okay, this thing moved around, and now it's sitting under the extensor tendon. And when we taught in the extensor tendon through the Mills manipulation, we were getting a compressive force on that aspect of the joint. And that makes sense to me. There's something sitting outside the joint space. There's no movement loss. And now we're compressing it from a different angle. So I just thought all of that combined together was really interesting. And I was really happy that all that happened, to be able to connect the dots of it all through this patient and to see it just work. So yeah, a bunch of that. 40 reps, I think, created another positive mechanical and symptomatic response and reduced pain enough to confirm directional preference. And we saw him again in 2 days. He said he was then about 70% better. Just reviewed everything, re-emphasized end range. Once again, didn't change anything. Gave him 7 days, and in a week's time, he was 100% better. No pain with anything. No functional deficits. So we saw him 5 times over 18 days, a little longer than the last patient. A couple changes had to happen.
Just a question about the load. So the overpressure was just doing elbow extension, right? Didn't have any glide, lateral, medial in this one.
No glide. Yeah, we tested loaded elbow extension with a lateral glide. Had no effect. And then I guess there was kind of an overpressure through. There was a fixation of the. You want me to show you the picture while I talk about it?
Yeah.
And so that's the move below there. And so really there's kind of an overpressure through wrist flexion because it's stabilizing. That was really the intention. The intention was posterior overpressure to the posterior joint, pushing it into extension while it was fixated in pronation due to wrist flexion. Again, in theory, and who knows if that's really what's happening or not, but to compress the exterior of the joint space.
Because I saw that when you did the lateral glide, I saw that the grip got better, like right away, but then the rest didn't get better. It was just the grip strength, and then you had no improvement.
The other thing that was significant is the after effect had no after effect. So during it felt better, it felt a lot. Yeah. Then you retested it right after, it was right back to where it came from. And I've experienced that quite a bit, where you can manipulate someone's pain while under that glide, but carryover isn't as good. I use it a lot as a diagnostic test as a rule-in for derangement, but
you can change it. You don't know how, but you can change it.
Exactly. And I think that's a good differential too. I'll use that sometimes with traction through a joint. If I traction someone's joint and it makes pain better, it indicates to me there's something in the joint space. It's joint. An articular dysfunction, you would think would just tauten it and make it worse. A contractile dysfunction shouldn't alter it in that way. Inflammatory state should alter it in that way. So if you can alter someone's pain through an accessory movement, in my opinion, I think it's highly likely that you have a joint derangement, although that may not indicate that's what directional preference is.
Yeah, makes sense.
Yeah. So 3-month, 1-year follow-ups, excellent, no recurrence pain. He continued to perform the reductive strategy prophylactically, I think a couple times a day for, I think probably in the short term for a few months, and then didn't feel the need to and stopped. And in a year, he was still fine. So another interesting patient, really good outcome. Blows away. I mean, these two patients, I know it's only two patients, not a large randomized control trial, but the efficacy of this blows away the short and long-term outcome of that randomized control trial. I mean, just wild, completely better in a couple weeks. These people were seen for like 2 months in their study, and then at a year, not better. It's like, that's crazy. It's exciting. But sometimes I think, especially in that first patient, if you just saw that, heard that, you're like, as a clinician, maybe, like, that's not that interesting. You just did one thing. That doesn't seem exciting or sexy or, I don't know, something that you would want to do. When you're in the middle of it and you see the patient excited and you see these crazy things changing, it seems that way. But I think that sometimes makes MDT seem too simple. People, if they're not experiencing outcomes in real time.
Yeah. The movement looks too simple, but all the rationale behind and the long-term results and all of that, that's crazy.
Right. And, if you look at really greater, for all of these patients, if you look and think about the greater societal implication that can cause. This person could have gone to PT for 3 times a week for 3 months, and then had a series of 3 cortisone injections, and then have to be out of work, and then all these other things that could occur if they get stuck in the medical system, get an X-ray, get an MRI, surgery. That equates to thousands and thousands and thousands of dollars, and people don't like that are part of that system that nurse got better in 3 visits and didn't do any of that because it takes away from what they do. Which I think is another issue with MDT being too effective. It keeps those people away. The other thing that I would never say this, I can't remember if I said this in one of our podcasts or not. They're all blurring together for me now. But I've heard, I didn't come up with this, I didn't say this, but that Mills movement, the wrist flexion, my father would want me to say this, so I'm gonna blame my father here. But I've heard people call that the Maccio maneuver. So I feel a little goofy saying that, even though I'm saying it right now for my father. If that sticks out there in the world, I'll take it. But it was
cool.
its kind, and I was extremely proud. It was presented in maybe I can't remember, it was 2017 Miami MDT conference. They presented that technique during an elbow workshop and presented the study and referenced it. So it was one of my proudest moments to see. So I was brought in by the faculty to show them how I do it and stuff. And it was like, still maybe early 30s at that point. So it really was a big step for me to
innovating in the McKenzie world. Yeah. Look at you.
Absolutely.
Very nice.
Okay. So our last patient is 43 years old. He's an IT consultant. He has constant right lateral forearm pain. Began during a tennis serve 3 months ago. So we got a little bit different of a differential than the first 2 people. They were kind of similar. He was given a medical diagnosis of lateral epicondylalgia. He had previous treatment of massage, ice, anti-inflammatory medication. All this had no effect. He had also stopped doing provocative things, playing tennis, using that arm in any way that was provocative, and it just continued on. So, and it limits keeping him from being able to play tennis, which was his goal. He really liked tennis and wanted to get back to it. Upper extremity functional scale 75 out of 80, average NPRS was 6. So if you look at if you think about the constant nature that we've been talking about, it kind of still inflammatory state still ruled in because of that. It's constant, but anti-inflammatory treatment didn't do anything. It's been resting it, it's been taking an anti-inflammatory, icing it, nothing's getting better. So you would think just removal of the provocative thing would quiet that down on its own, and then you add these other things into the mix, And that, in my opinion, at least, builds the case like, well, either it needs a lot more anti-inflammatory and a more directed cortisone injection or something at a higher dosage, or it's not an inflammatory state. And I see that so many patients come in, that's the first thing they try, an anti-inflammatory, and then it doesn't do a thing. And it makes a lot of sense to them when I go, well, I don't think this is an inflammatory state. It's not constant, but this general is. And I think in tying that into someone's education, because everybody thinks, especially in the exercise world, that it's contractile tissue or inflammatory, and do a lot of things to that tissue or to try to reduce inflammation without success. So inflammatory state is kind of on the table, but less likely because of that, in my opinion. And the constant component also really should rule out a dysfunction as the primary thing, because they're supposed to be intermittent. So contractile dysfunction, unless it was kicked into a reactive inflammatory state by playing tennis with it, shouldn't be constant, nor should it be an articular dysfunction. So it makes those two things less likely. Again, spine was excluded, and postural syndrome just doesn't have characteristics for that being constant. So it's likely that a derangement was also present, in my opinion, for those reasons. Upon physical examination, he had minimal loss of elbow flexion and extension, and a larger loss, a moderate loss of supination. So also a different presentation on this gentleman, movement loss, and none of the movements increased pain, which was interesting, because usually I see one at least cause end range pain. And he also fit the criteria for LE with positive special tests, resisted wrist, middle finger extension. So again, we went right into what I had been working with these other people. I was like, let's do it. Loaded elbow extension, tons of reps, no effect. Where would you go, Mariana, since you're getting to know how I think? Well, you already read this, so you probably know. What would your go-to move be if you were in this position?
I would probably try to add some different force, some lateral force, or try some supination, pronation, combine some movements.
Here, I thought you were going to say I'd definitely use the Maccio maneuver. But that's what we did.
Put that in the list.
For some reason.
Yeah.
And I can't really remember why we didn't apply lateral forces. I don't, to be honest, see adding lateral and medial pressure to extension do much. And I've had a lot of success with that the mimic Mills movement. So we went right into that, elbow extension, pronation, wrist flexion. I think I just did it to him with overpressure because it's kind of a weird move. I just wanted to see what it did for sake, before I spent a lot of time getting him to awkwardly do it. And I think he was a little awkward too, so I just did it for him, almost as if I was going to manipulate him. And further repetition of this abolished pain with gripping, with resisted extension, and trying to see if it abolished resting pain. I thought that it did, but yeah, I'm not seeing. We didn't comment on that. Oh no, yeah, it did. Overpressure abolished resting pain. So I think that's really interesting. That happened. Someone's had constant pain for 6 months. Now they don't, and they're like, "What the heck was that? You just turned it off that quickly? That's crazy." Also, it rules out an inflammatory state. As far as I know, that shouldn't happen in an inflammatory state. So again, we have another elbow derangement. Directional preference is extension with pronation and wrist flexion. And we saw the guy again in 3 days. Same thing. He came back with a 50% improvement, which you get it all right. It's not uncommon to see you get it all right day one.
The Maccio movement is working.
What that's
the Maccio.
Exactly. I was hoping that would start to stick to your vocabulary and listeners of the podcast too.
There you go.
Yeah, no longer had pain at rest, less pain with daily activity, and just reconfirmed the directional preference. It was still doing a positive thing. Told him to continue on, and we saw him again in another 3 days, and he said he was worse. I think this is interesting because this happens a lot where it's back worse, and I think it's quick to go, oh crap, I got to do something else. Let's get to my side, give him eccentric load, or change the movement, or relook at something else. And looking at, one of the first things I always ask is, if someone comes in and I go, how often did you do the exercise? And they go, it's been a crazy few days, I didn't do it at all. I go, oh, you're probably not any better. And that's usually the case. So he was not compliant. He had been busy, he stopped doing it. And basically the whole time we spent with him was re-educating him on why compliance is important. We reviewed the movement, it was still reductive, and we were like, this is on you. If you don't do this, you're not going to get better. You've already tried resting it for 6 months, icing it, taking anti-inflammatory treatment of that nature isn't helping you. You found something that's making you a lot better, but it needs to happen a lot. And this isn't my opinion. This is what the research shows, what prior patients experience. And if you don't, you won't get better. So usually, even before this happens, I'll often try to feel out how someone is. Certain patients are crazy compliant, certain patients are horribly compliant, trying to figure out and get them involved. And how are you going to remember to do this? What's your day look like? Do we need to set an alarm on your phone? Do you need to keep a checklist of how many times you did it every day? Do you need to make a chart that you can schedule? Do you need to correlate it with meals or times when you go to the bathroom at work or things like that? So kind of having a plan for that is another way to read compliance, which is,
I think,
super important.
I think that was a perfect example for the study, because I think that happens so many times when they come back and they say they are worse. The first thing we think about is like, the movement is not working. We have to try something else, like you said. And I think it was great to just stick to the plan. You tested it. It was still better after the test. So you just know that the patient has to be compliant, and you just have to trust on your assessment and don't get discouraged when they say that's not better. You retest, you keep your line of your rationale and keep going. That it's gonna happen what probably happened with you too.
Exactly, yeah. And again, in my earlier years of using MDT, that was a hard patient because I would get self-conscious and go, did I do the wrong thing? Is this really not working? And let them almost run the show, and then it would lead to them not getting better because I didn't do what needed to be done and wanted to avoid, I guess, an uncomfortable conversation or just a feeling of like, that's not a traditional, what you thought a traditional therapy session, physical therapy school would look like. I didn't do a thing. Just had to educate you and tell you, go do the same thing. Again, better about it. And figure out, I might try to fish for what kind of guy he is, how I can get in his head. How much do you like tennis? Do you want to play tennis ever again? Because 6 months is going by and you haven't been able to play. If you want to get back to it, this is the way. Or use things like that to kind of connect the importance of this problem. He's an IT guy. He's on a computer all the time. What if this gets worse? You can't use your right hand to keyboard or use your mouse. What are you going to do? So stuff like that I think is interesting. So anyway, we saw him again in a week. He was compliant. He's back not having pain at rest. He all daily functional activities were better, but pain was still provoked with tennis and forceful gripping movements. Range of motion at this point was fine. No movement loss. Resisted wrist extension was still painful, but required a lot more force to provoke. There's now this a lot, really forceful movement that provoked him. So just like with the second patient, we initiated force progression through that movement. through the Maccio. You know what? It's starting to feel right, actually. Maybe I am. And I overpressed them, mobilized them, and then I was like, I just want to exhaust all force. So I actually did the Mills manipulation on them to say, we've exhausted everything we can. It's not doing anything more. Movement loss without extension helping. We didn't write it. I can't remember because this was quite a while ago. We tested other movements at the time. And I probably would rescreen the spine again at this point and make sure that that had no bearing on symptomatic response before I called this contractile dysfunction. But we said this now fits the criteria for contractile dysfunction, and then initiated a remodeling strategy. We referenced this Cooling article, which was eccentric wrist extension 3 or 4 times a day, and then gave him a lot of time. And the visits here as to how long, because once that happens, in my experience, unless you missed it and you have an actual derangement, remodeling a contractile dysfunction takes a while. So educating that patient's expectation is important at that point, because this guy saw himself become maybe 60% better or something like that, and now there's this other problem that I know is going to take a while, but especially for a non-compliant guy, you just need to re-educate on the prognosis and the time frame and why that is. And I think that in using pathoanatomy to educate people about that at this point is helpful, because those are weird, goofy moves that people don't. I think I'm thinking about the Mercer Bogdov article when I'm using that, what exactly that's doing to the joint, to the tendon, to what kind of force we're putting through it, the biomechanics of it all. But for these people, this is just some weird move. It kind of feels odd. Why am I doing this? And don't get it. So I think educating them about why it's going to be different, why it's going to take longer, maybe providing research about it, which there's tons of, can be helpful. And then, we ended up seeing him overall for 6 visits over 59 days. So a much longer time frame, because we really spread out the remodeling process, as opposed to like the 11 days, the 18 days, and just the straight-on derangements. So this guy's also interesting because he had a derangement with an underlying contractile dysfunction, which makes it much more complicated. And we had him continue to do a little prophylactic extension with pronation and wrist flexion to make sure the joint derangement didn't pop back on. Because otherwise, in my experience, if you missed that and you tried to remodel, we already know that a lot of resisted wrist extension hurts him in his history. So if we left the derangement sitting there and tried to remodel him, we probably just would continue to irritate it and worsen it. Which is really interesting, because that has to happen first before the contractile component happens. I have no idea why. Did they come on at the same time? Did one cause the other? That's an interesting thing to think about. It didn't really matter in how we assessed it, but yeah.
In your experience, is that common? Do you see a lot of derangements and contractile dysfunctions in the same?
No, not really. I've seen a lot of people that need don't have a necessarily a contractile dysfunction, but once the derangement's reduced, they like doing some strengthening. It gives them some confidence. It gets some blood flow to the area. It kind of preps the musculature to return to higher level activity. So it's something I'll do a lot with people a couple times a day, but I think it more instills confidence. Like, I can exercise again. It feels good, but I don't see a true contractile dysfunction often with a derangement. It happens, and I'm struggling to pull stats on it, to be honest, because it happens, I think, so infrequently. Yeah.
Okay.
Yeah.
Just curious.
Yeah. So, again, we kind of already talked about this, but in looking at the comparative, we're now into the discussion section. the comparative of the randomized control trial, which basically used the same multi-module treatment for everyone. Now, if that happened, if we tried to do that for these 3 patients, they all had something different happen. So it would have failed. If we just said loaded elbow, loaded extension is my deal. That's all I like. That's all I do. I'm giving it to everybody. The one guy would have got the nurse would have got fully better. The other guy would have been stuck at 50% better. This guy would have been no better. So we would have gone from having, maybe a 40% efficacy to they all got completely better. And long term, this last guy at 3 months, he didn't answer his phone. At a year, he said he was good to go, no recurrence, back full on with everything, not needing to do movement anymore. And was very happy to be able to play tennis. So I think that's really important because you look at these multi-module or standardized treatments for people. There's a lot of themes out there that make a lot of people better, but like for instance, in these 3 people, they weren't cherry picked. They were just the people that were positive for an LE, and they're all different. So that just seems crazy to me that you would ever do that, and you're just setting yourself up for failure if that is how you treat people. So it makes sense that the efficacy of that study was horrible. Don't even do it. Just it's worthless, and and that makes me really frustrated because I see that in a lot of physical therapy. Sometimes I have a hard time telling people I'm a physical therapist because I see what they go through, and I get a lot of my patients used to be people that had failed therapy elsewhere, and they would come to me as a last resort to try to get that better. And it was just like, what were you doing? That's ridiculous. It was just embarrassing in my opinion. But those people probably say the same thing about me, but just don't get good outcomes or published research about it.
But that shows again about the medical diagnosis that these people came from and got full resolution pretty quick, most of them. So that's another time showing how the system fails.
Absolutely. And so, yeah, that just kind of was the gist of the first paragraph of the discussion. And then the other thing that was really interesting was all these special tests. So, one of them was the Cosins, one of them was the Mills. These are famous tests that have decent reliability. And they all immediately turn negative, from positive to negative for repeated loading strategies. And their goal or purpose is to rule in that you have a tendon problem. So, and that happens, that's been shown in a lot of MDT extremity research, that these special tests are basically useless. I got in trouble. I called them unreliable in this study, or I tried to, and they said you're using the wrong terminology. And in my head, it makes sense. This isn't a reliable test. It doesn't tell you anything. But they were like, 10 people could use this test and it would be positive, which probably would happen. So it's reliable in that sense. The word they wanted me to use was that its utility was poor. So it wasn't useful in determining structure. So it's nice as a baseline, but to use that to rule in a tendon issue is, in these people, was completely wrong. So for some reason, I really like pointing out about special tests. I participated in one of Richard Rosedale's shoulder study, which was really interesting. That I would assess the patient. My father did a blinded special test on them, and then we would track the treatment as to what happened. So I had no idea what would happen. And the same thing we saw eventually, that they all turned off after the reductive component strategy was there. So it's really cool that came out not too long ago. That all these special tests that we learned, that we spent hours and hours learning in PT school, practicing long nights, and just learning all these names, basically tell you nothing. But to use them as a baseline is helpful. And then again, just connecting the pathoanatomy here. And I know that MDT has veered away from using pathoanatomy as a guide, but I think as students it's helpful. Like me thinking and teaching the intervertebral disc model makes sense to people, to a patient, to a student. this is why you're doing this goofy movement. It's not for the same purpose that you're doing, cobra and yoga. It's intentionally repositioning something, and that's why your pain is centralizing or peripheralizing, and why you're going to get better. So, and a lot of people to connect that, you just say, I don't know what's happening. You just do this move. A lot of people don't like that. They need more. They come in with a lot of knowledge. They've researched this. In this day and age, everybody's on Google or Instagram or TikTok or something, learning more than you know about their problem. And so kind of just be like, I don't know what's happening, but this move's gonna help you. Makes you think, I think makes you look not on the same level as the surgeon that's gonna say, you got whatever pathoanatomy is wrong, and this is what's gonna fix it. So whether it's right or wrong, it's helpful for me as an educational tool and as a teaching to students and young clinicians and whoever. So anyway, I think just connecting back to that Mercer and Bogduk article is really interesting. It's these three different structures that can cause movement loss, cause nociception, that can move around, that you can move around with movement, that can get stuck outside the joint space, which is interesting to me because I don't see it a lot, but I've seen it in the knee, in the jaw, and some other joints where there isn't any detectable movement. And that shouldn't fit the operational definition of a derangement. And then they get better very quickly. So I think there's some exceptions to that rule. And I think this article displays that nicely with patient number 2, who second or third visit didn't have movement loss. And we use that compressive technique to the exterior of the joint space. And this idea isn't unique to Mercer and the Mercer and Bogduk article. There's another really interesting article that talks about the same exact thing done by Dupark. And we reference, I think it's Priscillus Mills, Dr. Mills, his article from the 1930s. It's like 2 pages, very clinical, like 70% efficacy. I think you knock people out and then do the manipulation on them. And he had wild success with it. He dissected some of them and found this ligament that was out of position that he theorized was an articular problem. And then somewhere along the line, the Mills manipulation got adapted by Cyriax, and Cyriax was calling it a tendon issue and using cross-friction massage, and then using the manipulation to break up what he theorized was scar tissue. But also saw his rapid changes through the manipulation, which it's like if you rupture scar tissue, it doesn't feel good.
It's not good.
It doesn't feel better. Yeah. You feel it hurts, and then it needs to go through a repair state. So then, in a way, to me at least, that never made sense. Which I guess all kind of connects to my interest in all of this. But anyway, yeah. So these derangements can mimic anything, and in this case, they're mimicking tendinopathy. And what's interesting is the treatment for tendinopathy is wildly different than the treatment for most derangements. Very uncommon that we even tension the tendon or need to strengthen it to get pain reduction. And if that's all you did, likely you just keep irritating. So, yeah, I think that's super interesting. It makes a lot of sense why the efficacy of these other randomized control trials is horrible, and basically says that you're better off not doing anything. So yeah, that was my first paper that got published. I was super proud of it. And yeah.
That's just not good for our PT profession. Not doing anything is the same thing as the same improvement, it's what you're doing. Like, what are you doing?
And a lot of these, and honestly, I see a lot of people that think they get better in PT, and it's just the passage of time. It has nothing to do with the intervention. They just go for a year. I mean, I can't help but laugh or be disgusted when I hear someone say that, but I hear that all the time. Oh, I was in PT. I was in PT for 2 years for my rotator cuff problem. I'm like, you just got taken advantage of, and that's horrible. I'm sorry. Here's my card. If you ever want to get better fast, let me know.
Yeah. And sometimes some patients also don't like the simplicity of what we give them, and they want to feel that they need surgery because they have that problem that showed in the MRI. Doesn't matter if you get them better or not. That's just too simple. Their problem is in the image exam, and they want to do the surgery. So sometimes it's also, as you said, the doctor with their diagnostic and their surgical powers. It's way more interesting for the patient than like a simple movement and technique that makes them better. Not all of them, but some of them, I see that a lot.
It makes more sense to people, the pathway, and more what people understand. And, I think in using, with those people, you giving them a research article that shows that is helpful, because then it's not my opinion. Here's the research. If you follow the science, this is what's happening. In the person that wants a lot of information, or figuring out, like we talked about before, what their understanding is and connecting that to that. Or just sometimes I'll go, yeah, if you're that committed to this being a rotator cuff tear, let's try to get it better. Oh, it's better? Good. I guess it could get better. Your rotator cuff's better. You don't need surgery. Just letting them have that and running with it, and not even going there. And if they ever care, and then, what, anecdotally letting them know, I see a lot of people post surgically that are way worse than you are right now. You run the risk of being worse. You have it in the back pocket, give it time. If you can keep it better, who cares?
Mm-hmm. Yeah.
One of the bigger issues is these people that are told they have bone-on-bone degenerative change.
Oh my goodness, that makes me so mad.
And right, we saw 40% of people that were told that in that Japanese knee study that were spine referral. So that's a very powerful statement to say to someone, and then usually the recommendation: stop moving it, stop exercising on it. They just keep it. And almost half of them are spine referral. The other 80% are knee derangements that are fixable. And in those people, that there's some interesting research that was done out of Stanford that shows that compressive loading of the articular space can regenerate it and make it healthier. So I'll use stuff like that to educate them. Like, you can make tissue healthier. And doing this isn't maybe not using the derangement model why it's getting better, but you're making your articular tissue better. And then using more extreme examples, like if you broke your leg and you casted it for a year, what do you think it would get, or for however long would it get better? When people conceptualize that getting better, but for some reason they can't conceptualize an aging knee getting better. And then just kind of getting into some of the incidental findings of those people that have no pain, and being like, I've seen the worst MRI in the world or X-ray in the world, and the person had completely fine knee. Long-term follow-up, they're still completely fine. Trying to find what connects to someone's education level of knowledge or what they want out of all of this. You're not going to get everyone, but that's the hard part. The easy part for me at this point is, that's movement. Go do that. I don't want to talk to you at all or give you any. Just go do this movement and be better. I like those patients.
Yeah.
But I got to get all this other data to it. So it's very draining.
Yeah. Yeah. Well, we can do what we can do. We can't help everybody. People don't want to be helped. So we do what we can. Well, this one I thought it was going to be shorter, but it wasn't. So
I had a call after this. I was like, I'll be out of here in 20 minutes. This one's easy.
It's going to be quick. And here we are. Okay. So I just want to thank you again for joining here the podcast and sharing with us all your rationale, why your reasons for starting the paper, the study, and everything behind it. So I feel like this is very, very helpful, and I think it's going to help a lot of other clinicians as well. So I appreciate your dedication and your time here with us. And I think we finalize our small series here of discussing papers. So thank you so much.
Thank you so much. It was a pleasure. And I hope that your listeners thoroughly enjoy and get a lot of clinical knowledge from it.
Yeah, and I also forgot to ask you if people want to contact you or ask you any questions. Is that a way that they can find you?
Sure. Yeah. I guess probably for clinical questions, if anyone has any, I often receive emails in that regard. So my personal email is my name, Joseph R. Maccio, at gmail.com. And if you reference this podcast, I won't throw you in spam, I guess. I'm happy to help educate the interested MDT community, and have done so for a long time, and will hopefully always be a provider of education for people that way. So yeah.
Awesome. Thank you.
You're welcome.